For many of the patients I meet who've been given a tentative diagnosis of a brain tumor or a brain cancer, when I meet them and examine their MRI, it's clear to me that they have a large mass in the brain that has a good chance of being a tumor, and that the size of that tumor might be causing them the symptoms that brought them to me, like headaches, or weakness, or speech trouble. For those patients, it may make good sense to combine the biopsy or diagnosis part with a treatment part, and an open surgery, which is sometimes called a craniotomy, to remove the tumor will not only give us some of the tumor to look at to make a firm diagnosis, but also relieve the pressure from the tumor and actually start help treating the tumor by removing as much of it as possible. For those patients that I meet, I usually recommend a craniotomy rather than a simple biopsy because I think it gets us farther ahead. Remember that both the biopsy and the open surgery require going to the operating room and usually require going under anesthesia. Whenever we can get a patient treated and get the best treatment in place with a single trip to the OR instead of 2 trips, that's always better. There are some risks to an open surgery. It's a surgery on the brain, and whatever part of the brain is nearest the tumor is the part that's most at risk. You would want to ask your surgeon, what are the areas of the brain that are near my tumor that might be at risk with surgery? Those are probably the same things that are getting pushed on by the tumor. So if you're weak in your right leg because of the tumor you have, then one of the risks of surgery might be to make that leg weaker. Our hope, of course, is to get the strength back in your leg by taking the pressure off it. But with any surgery, there is a small amount of risk. Usually the risk with a craniotomy for a tumor like this is on the order of about 5% chance of a major problem. Now, not all of those problems are permanent, and not all of those are irreversible, but patients should be prepared before they decide to go forward with surgery for the small chance that there could be a complication such as infection or swelling or bleeding from the surgery. A majority of patients who have a craniotomy to remove their tumor will be in the hospital 2 or 3 or 4 days, and when they go home should feel pretty good, but we'll find that they get tired very easily. A majority of them probably feel better from the standpoint of their neurologic problem, but it does take a number of weeks to really get over a major surgery like this. For patients who've undergone a biopsy procedure or an open removal of their tumor, craniotomy, it's very common for them to go home before the final diagnosis is available. I usually see patients back approximately a week after surgery, and at that visit I will make sure that they're doing well. I'll check on their medication. I'll often remove the sutures that were put in it at surgery. And most importantly, I'll be prepared to discuss the results of the pathology report. That means I'll have an answer about what the kind of tumor is. We've already talked a little bit about the grading scale 1 to 4 and the types of tumors, the astrocytic tumors, the oligodendroglial tumors, and there are some other less frequent tumors. But I'll relay this information to the patient and try to put that into context. It's very difficult to predict for a particular patient what will happen with whatever diagnosis. When doctors get numbers about a patient's prognosis, they think of it in terms of big groups of patients. If I have 100 patients with a tumor like this, in how many of those patients will that tumor grow back in the next few years? That's not particularly useful when I'm talking to one particular patient, because that patient is really concerned about how they're going to do. They wish the other patients well, but they don't want to know out of 100 patients what's going to happen. They want to know what's going to happen to me. We'll do our best to tell you about the type of tumor it is and what the different treatment options are, but understand that your doctor can't know for certainty for you exactly what will happen. Now, a very common question I get at this visit is whether we were able to remove the whole tumor or not. And you might think that that's really something that is up to the skill of the surgeon. But in reality, I think the type of tumor is the most important predictor of that. We know from experience that with the higher grade tumors, the grade 3 and grade 4 tumors, that even if we remove all of the tumor that we can see at surgery, and we remove all of the tumor we can see on an MRI scan, and we can compare one from before and after surgery, that there will always be little fingers of that tumor that are still left inside the brain. And the reason for this is in part because the tumor occurred in the brain. When we do surgery on the colon, for example, we can go a foot to the left and a foot to the right, and we can get some of the fingers of the tumor. In the brain, we can't take wide margins around the tumor, so there may always be tumor cells in the normal brain. This is why for a patient who has a grade 4 tumor, the surgeon may say, I took out all the tumor I could see and I don't see any tumor on the MRI, but I want you to strongly consider going forward with further treatment. And you might say, well, why do I need more treatment if you got all the tumor out? And that's because we can't see the little fingers, the little cells of tumor that might be hiding in the normal brain. But we can treat them with other forms of treatment, just usually not with surgery. So the main goals at the first visit are to educate the patient about the type of tumor it is, give them the details about the surgery that they may not remember from the hospital stay, and then start to talk about a treatment plan going forward. So as we've discussed, the first step in the treatment of a patient with a brain tumor is to get a diagnosis and to frequently remove as much of the tumor as can safely be removed. At this point, you may find that your team of doctors and healthcare professionals broadens, and you may meet a medical oncologist or a neuro-oncologist, which is a doctor who specializes in giving chemotherapy and medicine to treat tumors. And you may also meet a radiation oncologist. Now, that's not a radiologist. A radiologist looks at x-rays, like the MRIs that you probably had. The radiation oncologist treats tumors with radiation. And often at this point, the neurosurgeon, someone like me, will take a step back on your team and be a supporting member of the team. And the medical oncologist, partnered with the radiation oncologist, will take the lead in treatment. Some patients with very low-grade tumors, like grade 1 tumors and some grade 2 tumors, who are young and have had a very good removal, might just elect for observation at this point, meaning we would do a series of MRI scans over months and years to follow for any sign of the tumor coming back. It's very important for anybody diagnosed with a brain cancer to have a long-term follow-up plan. And it would be very unusual after surgery for me to tell a patient that they didn't need to come back anymore, even if they were only coming back for scans. So if you hear that you don't need any more MRIs or anything else done, it would be very good to ask and make sure that that's clearly the point, because most patients will at least get follow-up imaging. Many patients with grade 2 tumors, and almost all patients with grade 3 and grade 4 tumors, even after the best surgical resection, will hear recommendations from their treatment team to consider chemotherapy or radiation therapy, and sometimes the two are given together. It would be very common to set out a treatment plan that would go on for a number of months, and it might be that the patient would get radiation as the first step, maybe with a low dose of chemotherapy given at the same time, then take a brief pause, and then move on to getting regular chemotherapy for a defined period of time, or at that point the period of time may not be known. So you should often expect to hear at this visit about a treatment plan that would involve both radiation and chemotherapy. Obviously, this has to be individualized for each patient's case. The goals of the doctors and nurses treating you for your brain tumor, as they set out the first treatment plan after surgery, are several. The first is to protect the function of your brain and keeping you or your loved one functioning at the highest possible level. Because the brain is involved with the tumor and is such a key organ to who we are and what we think and what we do every day, we have to pay special attention to brain function and the impact of both the tumor and the treatment on brain function in order to maintain very high qualities of life for our patient. The goal of all of this treatment is to find the tumor cells that either can't be removed or can't be seen on MRI, and to treat them. Those that aren't visible on MRI are very difficult to remove surgically. But every tumor cell has a blood supply, and that blood supply can be used to deliver chemotherapy. And every tumor cell of a brain tumor is in the brain somewhere, and radiation can be used to target those. So at this point, chemotherapy and radiation often become the mainstays of treatment. It's very common for patients who've been diagnosed with a brain cancer to undergo radiation therapy as a part of their treatment plan. Let's talk for a couple of minutes about what radiation therapy is, how it works, and what it's like for patients who go through it. The goal of radiation is to find the tumor cells in the brain and to treat them while sparing the surrounding normal brain tissue. Usually this is done by spreading the radiation out over a number of weeks. This allows the brain cells to heal each day, so you might come each day during the week and get a small radiation treatment, and both your normal brain and your tumor would feel that radiation. But the brain has the ability to heal, and so each night the brain can improve, and the next day you come for a little radiation, and everybody feels that, but overnight the brain heals. And over time we hope to create a treatment effect where the tumor is very affected by the radiation, but the brain maintains its normal function. And this is the primary goal of radiation. It can be a very powerful tool in treating brain tumors. Some tumors respond beautifully to radiation, and we call those radiation-sensitive tumors. Other tumors don't respond very well to radiation, and those are obviously called radiation-resistant tumors. It may be difficult to know whether your particular tumor is sensitive or not to radiation without treating it and seeing what the response is. The vast majority of patients with brain cancer will get radiation at some point in their treatment. The radiation involves small doses every day. It's not particularly painful, it's not particularly dramatic, but it does make many patients tired. It does have some potential side effects like any cancer treatment, and you should ask the radiation oncologist, the doctor who specializes in radiation treatment of cancer, to explain to you the particular risks that might come from giving radiation to this area of the brain. It's very common for patients diagnosed with brain cancer to get chemotherapy as part of their treatment. There are many different kinds of chemotherapy that patients get. The simplest ones are pills that may be taken lifelong. The more complicated ones may involve multiple chemotherapies which are given through IVs or infusions and require people to be in the hospital. I'm going to talk a little bit about the most common chemotherapies that are used for brain tumors. Fortunately, the most common drug that's used for treating brain tumors is a drug called temozolomide or Temodar. This is a pill drug. It's often given over a 5-day period, say the first 5 days of the month, and then the patient has the rest of the month where they don't take chemotherapy while the drug is working in their system. While no chemotherapy is without risk or without some side effects, this is a drug that's easier to take than many of the chemotherapies. As I meet patients who are very nervous about starting chemotherapy, I'm comforted to know that I can reassure them that the first drug that we'll frequently use, this Temodar or temozolomide, is very well tolerated, and frequently patients are able to resume work or other normal activities while they're taking the chemotherapy. It usually doesn't make your hair fall out either, which is good for patients who have a tumor on the head and in the brain. Temozolomide is not the only chemotherapy that's used for brain tumors. There are a number of different chemotherapeutic drugs and even non-chemotherapeutic drugs, which we now call biologic agents. These are therapies that target particular weaknesses in the tumor cells, but work in a little different way than the traditional chemotherapy. And there are many of these types of drugs that are used to treat brain tumors as well. One very common one is a drug called Avastin or bevacizumab. And this is a drug that targets blood growth within the tumor. And it's a very common drug for patients with brain tumors to get. It's usually given after the temozolomide is given, but there are studies and treatment paradigms where it's given at the time of the diagnosis of the tumor. This is something you'll want to work out with the neuro-oncologist or medical oncologist who's involved in your care to decide what would be the right order of the drugs to best target your particular tumor. Even after we've used temozolomide and Avastin, this bevacizumab, there are a number of other chemotherapeutic drugs that can be used. So even if one of these first two isn't the best drug to target your tumor, there'll be other options that are available. Many patients are comforted to know that there is a rich network of researchers and doctors around the world working day and night to find new treatments for brain tumors. When these treatments are first available, they're usually done as part of clinical trials. many patients who have a brain tumor will find themselves treated on a clinical trial. The clinical trial may test existing drugs used in new combinations, or it may test a brand new drug that's not been used for brain tumors before. All clinical trials involve a certain amount of risk and require very careful explanation from the physician or researcher who's running the clinical trial to explain to the individual patient what the benefits and potential risk would be of that. All of the treatments that we give today at one point were tested in clinical trials and were found to have a positive results. Those trials went on to be our standard treatments that we use today. The hope of the future will come from the drugs that are in clinical trials today. The decision about whether or not to join a clinical trial is a very personal one, and each patient and their family make that for themselves. Every patient weighs for themselves the standard treatments that are available versus things that are available in a clinical trial. Remember, everything that we use today as a standard trial was in the past part of a clinical trial that proved to be successful, and that moved over to being a standard treatment. You and your oncologist and your family will decide whether a particular clinical trial offers enough promise and hope for you to choose that over a standard treatment, or you may move to a clinical trial after you've tried one of the standard treatments and it's not working as well as we would like. There's tremendous promise in the new drugs that are being tested in clinical trials, but there's a certain amount of uncertainty about how effective that drug will be and what the side effects would be. Nothing goes to clinical trial without very careful testing to try to pinpoint any major complications. A particular drug that's very unsafe would never make it to a clinical trial. It's important to weigh clinical trials and standard therapy in order to chart the best course for you or for your loved one. You may be approached at the time of your surgery or biopsy to donate some of the tissue for study, and you may wonder why that's being done. Let me take a moment and explain that. Much of the progress that's been made in fighting cancer in the last 1 and 2 decades has come from studying the tissue that was removed from patients, looking at the genetic alterations, and then designing treatments that are aimed at these weak spots in the tumor. Nowadays, we can take your particular tumor and test the genome, and we may be able to pick particular tumors for you based on what we find in your own tumor type. This is really the start of personalized tumor therapy. I think it's very valuable, whenever possible, to bank and store that tissue so that it can be used not only to benefit you, but also to benefit others who are diagnosed with the same type of tumor. I always encourage, but never require, my patients, if there is extra or leftover tissue, to allow us to bank that tumor and, with certain restraint and guideline, use that to find new treatments both for them and for others diagnosed with brain tumor.